Good morning, ladies and gentlemen, and welcome to the first E3 International Cancer Conference here live in Kigali. I want to welcome you all. My name is Walter. I'll be your host, and today I'm so privileged. I'll be hosting this conference with my co-host called Dr. Ndoli. Dr. Ndoli is an oncologist in the military hospital here in Rwanda. Dr. Ndoli, can you come? Can we give a round of applause to my co-host, Dr. Ndoli? Dr. Ndoli, welcome to the program. Can you tell us and greet the people, and we continue.
Thank you very much, Mr. Walter. Good morning, everyone. So while welcoming people, we usually welcome them in my native language. Do you know how they say welcome?
What is your native language? I don't know. You can tell me so that I know what's your native language?
Please guess.
Rwanda.
Oh, yeah. So he knew my native language is Kinyarwanda. So in Kinyarwanda, they say Murakazaneza.
So when you say Murakazaneza, how do I respond to Murakazaneza?
Maybe if you can tell the people Murakazaneza and you get their response. What if we do that?
Murakazaneza. So welcome, thank you so much, Murakazaneza. Then we say Murakoze Chane. Murakoze Chane is thank you. So ladies and gentlemen, we just want to run down the program today, and we are so privileged to have this conference here at ICAD, a center where we are going to be deliberating a lot of topics, and we are here. Without further ado, I just want to, you know what's going to happen, Dr. Ndoli? We have a great day to call upon the next speaker, and I want to tell you the profile of the next speaker to give us the official welcome remarks. The welcome remarks, we have got a distinguished chartered accountant, an entrepreneur, driven by the passion to foster the ongoing culture of improvement. This person, he's in the building. He is the group managing director of JKK and also the managing director of E3 International. He is amongst us. Ladies and gentlemen, this speaker, his profession shines mostly in the realms of freight and event management in the industry, where he has implemented successful strategies to boost operations, profitability, and performance. He is particularly adept at organizing tasks, setting priorities, and delegating duties to achieve safe delivery goals. Moreover, this speaker, ladies and gentlemen, allow me to tell you the presence of JKK and also E3 International Conference is in the countries like India, UAE, Africa, USA, and E3 International Limited, it focuses on four main things: event organizing, trade shows, trade delegation, conference, and exhibition like this conference. Ladies and gentlemen, help me to welcome Mr. John Koshi to the stage. He's the group managing director of JKK, and also he is the managing director of E3 International Conference. Help me, ladies and gentlemen, to welcome Mr. John Koshi to the stage to give us welcome remarks. Mr. Koshi, to the stage. Can we give a round of applause?
Good morning, everyone. Dear Director General Professor Claude Muriveni, representing Ministry of Health Rwanda. Dear Dr. Brian Chirombo, country representative representing World Health Organization Rwanda. Dear Professor Jack Maresco, President and founder of IRCAD Africa. Distinguished participants, ladies and gentlemen, good morning once again. John Koshi is my name, Chief Executive Officer of E3 International Limited. It is with immense pleasure and a profound sense of purpose that I welcome you all to the first edition of E3 International Cancer Conference, where we gather under the theme of Bridging the Gap, advancing cancer care, research, and education in Africa beyond post-COVID era. In these unprecedented times, as we navigate the complexities fashioned by the global pandemic, it is more crucial than ever that we come together to address the pressing challenges facing cancer care, research, and education in Africa. The theme of our conference underscores the urgent need to build bridges, bridges that connect us, bridges that transcend boundaries, and bridges that lead us towards a future where cancer is no longer a death sentence, but a conquerable foe. Africa, with its rich diversity of cultures, landscape, and people, present both unique opportunities and formidable obstacles in the fight against cancer. Despite the remarkable progress made in recent years, much work remains to be done to ensure equitable access to quality care, to drive innovative research, and to empower future generations through education. As we stand on the precipice of a new era, one marked by resilience, adaptation, and renewal, let us seize this moment as an opportunity to chart a bold new course forward. Let us harness the lessons learned from the COVID-19 pandemic to strengthen our resolve to foster collaboration across borders and to accelerate progress towards our shared goals. For too long, cancer has exacted a heavy toll on the people of Africa, robbing families of their loved ones, undermining economic development, and perpetuating cycles of poverty and despair. But today, as we gather in this virtual space, I am filled with optimism and hope. I see a vibrant community of stakeholders, from clinicians and researchers to policymakers and advocates, united in their commitment to effective, positive change. I see the seeds of innovation taking root as new technologies and approaches emerge to revolutionize cancer care. And as I see a shared determination to ensure that no one is left behind in our quest for a brighter, healthier future. Over the course of 2 days, I have no doubt that our discussions will be lively, our debates spirited, and our insights profounded. But let us never lose sight of the ultimate goal: to transform the landscape of cancer care, research, and education in Africa and beyond. In closing, I extend my deepest gratitude, each and every one of you, for your unwavering commitment to this noble cause. Together, we have the power to change the course of history, to rewrite the narrative of cancer, and to create a future where we hope triumphs over despair. Thank you, and may this conference be a source of inspiration, collaboration, and hope for us all as we look forward to make this event an annual event in Rwanda. Thank you once again.
I just wanted to remind us our theme of today is Bridging the Gap, Advancing Cancer Care Research and Education in Africa Beyond the Post-COVID Era. So our discussions today and tomorrow are going to be around this theme.
Greetings on behalf of the Scientific Committee of the E3 International Cancer Conference in Kigali, Rwanda. My name is Dr. Monirul Islam, and I led the scientific committee of this conference. The committee was involved in the initiation, development, plan, and assessment of all scientific needs of the conference. The committee also identified the speakers, panels, and review abstract for this conference. Let me take a few minutes time emphasizing the rationale why we picked up the cancer conference in Rwanda in Africa. As you know, the cancer disparities are prevalent across the globe. But some regions experience disparity far greater than others, and African continent is fall in this category. We know the country with low human development index score are more likely to experience a higher burden of infectious diseases, but at the same time, due to globalization, these countries are experiencing the burden of chronic disease, cancer, as well as at the same time when it is also taking the burden of infectious diseases. As you know that according to the UN, 33 of the list out of 45 least developed countries are on the continent of Africa. This is based on 2024 data. According to 2020, South Sudan had the lowest Human Development Index score. At the same time, if you look in one of the North American country like Canada, which had 0.93. If you look at the European countries like Switzerland, Denmark, Norway, Finland, they have 9.6. The reason we are here gathering today to emphasize that there is a greater need for cancer research, education, care, innovation in African continent. Cancer was the 5th leading cause in Africa in 2020, and it was responsible over 700,000 deaths in the continent. Whenever we compare two countries or two regions about the disease burden, we always try to compare utilizing age standardized incidence rate, mortality rate. As you can see, as I'm trying to give you two very fundamental numbers. If you look at these data, African continent on average, there was 132 cancer death per 100,000 population. At the same time, there was 88 deaths per 100,000 population. If you look at the data at the same time in North America, the cancer incidence, age-adjusted incidence was over 3 times, which was 365. But the mortality rate was same, 88 per 100,000. So there is a big disparity in cancer mortality between the developed and developing countries. You might ask question, why this higher mortality between these two different economically society? Because the individual we diagnosed with cancer in developing countries, more specifically to African continent, either do not receive adequate treatment on time or being diagnosed at the latest stage and do not respond to the treatment. So this is the current status. We have very similar cancer deaths or mortality when we have only 1/3 of cancer incidence compared to the developed country. Imagine from now on in next 5-10 years, as you can see that the economical development in the African continent and human development index are improving. that translate into less infectious diseases, more life expectancy, and we expect higher incidence rate in this population. If we cannot address or try to intervene by screening or early diagnosis and providing quality care for cancer, the mortality rate would be double, triple in next 10, 15 years. So let us work together in coming years to address cancer care, research, and education in Africa. That is why we are here together. We are together in this fight, and we are very optimistic that we will win the fight against cancer in coming years. Without further due delay, I welcome you and enjoy the conference and the beauty of city of Kigali, Rwanda. Thank you very much for your attention and have a great day. Enjoy the conference. Take care. Bye-bye.
Thank you. Let's give a round of applause to Professor Claude Mambo Muvinyi to the stage.
Good morning. I have to say I'm not Professor Muvunyi. Maybe I will be closer to him in the next years. But he couldn't make it because of another urgent meeting, and then I'm here to represent him. Myself, I'm Dr. Albert Ishime. I'm the head of Diseases Prevention and Control Department at Rwanda Biomedical Center. And it's a pleasure for me to be here in this conference. Dear Dr. Brian Chilombo, dear Professor Jacques Morisco, dear John Koshi, leaders of different institutions here present, distinguished participants, ladies and gentlemen, good morning again. It is with great honor and privilege that I welcome you all to the E3 International Cancer Conference here in Kigali, Rwanda. As we gather under the theme, Bridging the Gap, Advancing Cancer Care, Research, and Education in Africa beyond the post-COVID era with data, we are embarking on a journey of collaboration, innovation, and dedication towards a common goal of enhancing cancer care across the African continent. As you all know, today the world is facing an increasing burden of cancer diseases. If you look at the recent estimates released by World Health Organization back in 2020, there were 19.3 million new cancer cases and 9.96 million cancer-related deaths. This is a significant increase from the figures of 2012. Therefore, we have to act now as the cost of inaction is very high. In the wake of the COVID-19 pandemic, the world has faced unprecedented challenges, magnifying existing disparities and exposing vulnerabilities within healthcare systems globally. Despite these challenges, our resilience shines through as we come together to address one of the most pressing health concerns of our time, which is cancer. The theme of this conference underscores the imperative to bridge the gap in cancer care, research, and education in Africa. With the focus on leveraging data-driven approaches, we should be aiming to not only address the immediate needs of cancer patients, but also to pave the way for sustainable, evidence-based strategies that will shape the future of oncology on our continent. Africa is a continent of immense diversity with unique healthcare landscapes and varying levels of access to resources. Yet, in the face of these diversities lies an opportunity for collaboration and mutual learning. By harnessing the power of data, we can identify common challenges, share best practices, and tailor interventions to the specific needs of each community, and thus ensuring equitable access to high-quality cancer care for all Africans. During this conference, we should be aiming to engage in insightful discussions, exchange groundbreaking research findings, and forge meaningful partnership that will propel us towards our shared goal of a cancer-free Africa. From innovative treatment modalities to cutting-edge research methodologies, let us harness the power of data to drive progress and transform the landscape of cancer care on our continent. We extend our deepest gratitude to all speakers, participants, organizers, and sponsors who have contributed to making this conference a reality. Your commitment to the fight against cancer inspires us all, and we are confident that together we'll make significant strides towards a brighter and healthier future for Africa. We thank you and urge everyone to embark on this journey together with determination, compassion, and hope. I thank you very much.
For the day, we are going to introduce guest speaker, Professor Jack Maresco, to the podium. Can we give a round of applause to Professor Jack Maresco to the podium?
Thank you very much. Thank you very much, and thank you for this kind invitation. I'm going to speak, because it is an oncologic congress, about what we develop in IRCAD France, and especially how we imagine the big change that artificial intelligence are going to transform, to revolutionize the minimal invasive surgery. So that is just a little view of IRCAD France. We start by one building, and now we have 5 buildings dedicated to minimal invasive surgery, especially with oncological application. And we have 2 departments. One is research and one is training. Since the beginning, when you discuss with a surgeon about how he can improve his procedure, the answer is through what we call augmented surgery. And we work on this topic since more than 25 years now. What is the concept of augmented surgery? The first one is augmented vision, augmented eye. When you discuss with a surgeon, the first thing he would like is to see more than what his eyes are able to see. And that is everything, you know, that optical imaging like endocyanine, ICG, but also multispectral, hyperspectral. But we work a lot on the concept of augmented reality. That means how we can see in transparency. For example, if you need to operate a cancer of the liver, how we can see in transparency to avoid any complication. So that is the first augmented eye, augmented vision. The second one is augmented hand, and that is robotics. And you know, when we published in 1998 the first 100 patients operated by a robot, everybody said that we were totally crazy how the robot could replace the hand of the surgeon. But now we know that we have 136 companies of robotics in the world. And especially we will see a new generation of robots for endoluminal surgery because we detect in an early stage now the cancer of alimentary tract. And finally, we have artificial intelligence, which is involved in all this topic. They involve in the augmented vision, involved sure in the robot, because the next generation of robots are going to be smart robots. So one word about, we need artificial intelligence in each step of surgery. And we know everybody thinks that surgery is just a procedure, how we can remove a tumor. No, the most important thing is one, the diagnosis, and second one, the strategy. So for the diagnosis, what is going to change totally today by artificial intelligence is that we detect the undetected tumors. And you all know for the colon, it's common, because for the colon, you have a lot of systems by Olympus, by Medtronic, which is genius. You see, we can absolutely detect a little polyp of less than 5 millimeters, a plant polyp that is impossible to see with your eyes. And immediately you know if it is an hyperplasia, that means no risk of cancer, or if it is an adenoma. And if it is an adenoma, you absolutely need to remove this adenoma to avoid any risk of cancer. So we know that for colon now it's nearly not a routine, but it's more and more developed in all the country. For the stomach, to do the diagnosis of early gastric cancer, it is absolutely more difficult because the stomach is a big pouch. But you see that today it is possible, especially by the huge development in China. And look, for example, this company, but you have other company. But this company, I think, with approximately 4,000 engineers in artificial intelligence, you see that they are able to do the automatic diagnosis of early gastric cancer, and that the results are absolutely better with the machine than by the gastroenterologist. So you need just to understand that everybody says the machine is just going to be a support for the medical doctor, but more and more the machine is going to replace the surgeon to do the diagnosis, especially to do early diagnosis. And you will see also why it is so important. It is so important because if you do an early diagnosis of cancer of esophagus, stomach, low colon and rectum, you change totally. It will be no more a normal operation or a laparoscopic operation. It will be an endoluminal surgery. And endoluminal surgery, you will see, needs a new platform, especially a new kind of robot. So after that, we speak about, diagnosis first. How to have the early diagnosis. Secondly, strategy. Strategy is the most important thing. You can perform a fantastic procedure, surgical procedure, but if the strategy is not the good one, it's really the definition of a failure. And what is very interesting, some weeks ago, we had a course, an advanced course of 1 week about rectal cancer and colon cancer in IRCAD. And for this kind of course, we invite approximately between 25 and 30 key opinion leaders. That means the best surgeon in this field in the world. And the last day, always we propose some difficult case. And during the last course, some weeks ago, the question was, you have a young lady of 42 years old. She has rectal cancer, T3NO. She had a radiochemotherapy and the tumor disappeared. What to do? So we have the 3 best key opinion leaders in the world. The first one say, even if the tumor disappears, you need to do a TME, a total mesorectal excision, because there is a risk of recurrence. The second one say, no, you need just to do a full thickness by endoluminal way, transanal way, and a lateral lymph node dissection. And the third one say, no, you need just to do wait and watch, nothing. So in real time, in 3 seconds, we ask the question to ChatGPT-3. In 3 seconds, ChatGPT-3 said, you have 3 proposals. These were the 3 proposals of the key opinion leaders. You can do a TME, you can do a lateral full thickness dissection, you can do wait and watch. But, and that was the immediate conclusion, because the lady is 42 years old, never propose a TME because the quality of life will have a lot of problems. And we know that more than 85% will be totally cured by the radiochemotherapy in this case. So you need absolutely to propose wait and watch. So you imagine that the first machine learning was, if you remember, more than 10 years ago, Watson by IBM. But Watson was $300,000 per year. Today with ChatGPT-4, it is $20 per month. It will be $10, $5 certainly. That means that the patient will have access to ChatGPT. And that means that during the discussion between the surgeon or the medical doctor, the oncologist and the patient, it will be totally different, because the patient can discuss with ChatGPT-4. And you know also that in New England Journal of Medicine, they have a fantastic article where also the machine was considered to have more empathy than the medical doctor by 100 patients. Why? Because with ChatGPT-4, you put a lot of new keywords you can discuss during 1 hour if you want. With a medical doctor, after 15 minutes, he has no time. So that is why it's going to change. Now, how we use artificial intelligence in preoperative planification. That is so important. Look, this baby, he has a huge hamartoma of the liver. So the pediatric surgeon was concerned about how to start the operation. And you see that if we have a 3D reconstruction by algorithm of virtual reality, we can navigate inside the tumor. And you will see here, we see the right hepatic artery and just 2 arteries going for the vascularization of the tumor. So for the pediatric surgeon, he has just to control these 2 arteries and the operation was totally finished. The same, an example which is very interesting, cholangiocarcinoma of the liver. We show that to our advanced course of hepatic surgery, and all the key opinion leaders, especially all the Japanese teams, they say, oh, this cholangiocarcinoma is on the right side of the liver. You have to do a right hepatectomy for the cure. And when you use the 3D reconstruction, you will see we have transparency, so immediately we have everything. Difficult to understand, so we remove the biliary tract, we remove the arteries, and now we have just the vein. And we see that the tumor is absolutely not on the right side, but because we have an abnormality with no median vein, the tumor is on the left side. And immediately we know, because we can put a virtual crypt, that the operation to perform is just the opposite of the operation plan. That is a left hepatectomy. So just I want also to show you that also a revolution for cancer of the colon, because with a 3D reconstruction, everybody can see very easily where is the tumor, what is the exact vascularization of the colon, where are the lymph nodes, and you see that today we have not to adapt during the operation because we understand everything before. One thing to say why it is important now with artificial intelligence, because we have created a spin-off, which is Visible Patient, and we are able to reconstruct all these organs before the operation. But the problem is that it was long before the COVID. Look, for example, if we want the reconstruction of a lung cancer, you see that before the COVID, that means 2019, to have the trachea, to have the bronchus, to have the arteries, the vein, it was 4 hours semi-automatic. That means 2 technicians of radiology. And because during the COVID, we gave to the machine thousands of cases of lung anatomy. The machine learned a lot. And you see that in 1 year today, from 2019, 4 hours semi-automatic, 2020, 9 minutes fully automatic, no human resource. Now, 2023, 3 minutes, and we imagine that in the next 5 years, it will be real time. That means automatic real time. That means if, for example, the robot is connected to the PACS of the hospital, in 1 second you push on a button and you will have the 3D reconstruction of the clone, the digital clone of the patient. Another way today is automatic anatomical structure recognition by artificial intelligence. So today we have done only, not for cancer, you see for cholecystectomy. Cholecystectomy is a very simple operation, but 5,000 severe complications per year in the United States. And we know also by the consensus conference that if we are able to have a perfect dissection of what we call the triangle of safety, we have no complication. The machine can understand that. And immediately, if the surgeon wants to continue the operation without a perfect dissection of the triangle of safety, he has an alarm. Or if it is with the robot stops, doesn't want to continue the operation. And now it is a start for cancer, because in Japan they do the same for automatic recognition of ureter, arteries, vein. But the fact is that in Japan very often there are no fats. That means you can see in transparency, so the machine easily can detect this kind of anatomical landmark. The next step is the simulation before the operation. That didn't exist before, but you see, for example, we have 3-4 metastases of the liver to operate. So we know on the computer that we have to do a 3-segmentectomy for the left metastasis. For the other one, we need to do a radiofrequency ablation or cryoablation. And you see that because it is not a 3D CT scan, because it is virtual reality, we can have an interactivity with equipment. We take, for example, the needle, you see, and we know exactly what is the best way to be in the center of the tumors. And we can take all the different instruments. Here, for example, we take the camera, we take the grasper, the scissors, and on the left, we see in transparency what we are going to see during the operation the day after. So that is what we call the preoperative simulation. And now we have the integration. That is the next step, is smart robots. So here it's a rectal cancer operated by the director of IRCAD in Brazil. He was in Strasbourg. It was a complex case. And you see he's operating with the Da Vinci system. So he's totally immersed in the master part of the robot. But he has like a GPS. And you know that today, all the cars, they have a GPS. So it's the same for surgery. It is not the superimposition. It is not augmented reality, but it is a GPS. So he knows all the abnormality of the anatomy during the operation. So that is also a fantastic new step. And the last step we want to arrive to do, but today it's difficult, is the fusion. To be sure to see in transparency, that is a fusion between the preoperative 3D image and the real image you see, which is difficult because it moves. So that is the reason why with Siemens, Siemens will be a huge partner of IRCAD Africa also, and you see that we have elaborated what we call a smart hybrid operating room. So it's fantastic. It is a Rolls-Royce, it is a Ferrari, because in the operating room we have the CT scan, we have the MRI, we have the robotics CT scan. So we can do what we want for hepatic surgery, for example. During the operation, we have the exact anatomy of the vessels, but we need to have the biliary tract. So during the same operation, we can have an MRI. So it looks fantastic, it is fantastic, but it is not reproducible, because this kind of operating room, it's more than $7 or $8 million. So you imagine it's impossible to reduce. So it was a clinical research, which was very interesting, but absolutely impossible to reproduce. One word about a big transformation of alimentary tract cancer. We know that we are going to detect the cancer at an early stage. That changed everything, because that will be the open door for endoluminal surgery by flexible endoscopy. But there is a problem that gastroenterologists today, they use an endoscope with the two instruments going out of the flexible endoscope in a parallel way. And we know that there is one rule in surgery. The rule is triangulation. If you have not triangulation, you cannot operate. And that is the reason why we develop a lot of prototype, especially with Karl-Storz. And today, you will have one on the market. It is an American one, and here it's Professor Xavier Serra-Aracil, chairman of rectal cancer in Barcelona, in Spain. So you see on the ex vivo model, we have a flexible endoscope. We put the endoscope in the rectum, and we can have some, for example, ESD, endosubmucosal dissection, but we can do everything. We can do also a suture. So you imagine that is a revolution. It was totally impossible to do a suture by endoluminal way. So you imagine that today, if you have the detection of early cancer for alimentary tract surgery, that will be an ambulatory way for the treatment. And that is for the next 10 or perhaps 20 years. It will be long, but sure, due to the early detection, it will be the future. And now another one, a company which is fantastic, that always, Chinese, because every year they have 5 new robots in China. And you see that they have also this kind of new robot, but something is fantastic is that you will see a triangulation of more than 11 centimeters. So that means they have no limit for gastric cancer. If you want to do, for example, a full thickness of the gastric wall, it will be possible. And that will be certainly on the market in the next 2 years. One word very important for oncology surgery, it is remote telesurgery. We had a consensus conference in Orlando in the United States 2 months ago about that. It's funny to say that we had in 1994, so imagine 30 years ago, we had a grant from Europe to develop remote surgery. And it was the first time that we have performed a remote surgery. It was a cholecystectomy between New York and Strasbourg. I was in New York, my patient was in Strasbourg, and it was the first time that we have done this kind of operation, which has been published in Nature in 2001. That was a Lindbergh operation. So it was not a surgical challenge because it was an easy procedure, but it was a challenge of information age. How it is possible to do a precise surgery with more than 14,000 kilometers. So that was the setting of the robot. At this period, it was Zeus robot. So imagine that was more than 22 years ago. And you will see a lot of engineers, more than 80 engineers of France Telecom, because at this period, the problem was a delay. So that was the platform in Paris. And I was personally in the subsidiary of France Telecom in New York. The name was Equant, and the operation was performed and published in Nature. But what happened now? Now, 20 years ago, it started just in 2020. First trials in China with 3,000 kilometers. It was a preclinical data. And after that, explosion in 2023. In 2023, 100 cases performed with remote surgery because in China, they say that is the only way for what they call healthcare equity. Because China, they have fantastic hospital in Beijing, in Shanghai, in Hong Kong, but in all the area, they have nothing. So the only way to develop minimal invasive surgery will be remote surgery. So the same for Japan. You see, Japan, they have done a lot with the Kawasaki robot Medicaroid, a lot of internal, that means in Japan, remote surgery, but also from Japan to Singapore. And look that, it was a kidney cancer. And the kidney cancer, it was a triple consult surgery in China. That means 3 surgeons in Beijing operated in 3 different hospitals in China. And that is really a revolution. And we want absolutely to do the same. I know that we are going to discuss in 1 hour with the Minister of Health of Rwanda, because we have a program to do the same on the African continent, because I think that is also the future to democratize minimal invasive surgery for cancer. A word about real life. What I show you just before, we all dream. It's fantastic. It is what I call the Ferrari or the Rolls-Royce. But that is not the real life. And during the COVID, I had the possibility to discuss with one of the directors of WHO. And I discovered something certainly you know, but that I didn't know, that 5 billions of the worldwide population don't have access to a medical imaging. That means a simple X-ray of the lung. And in the Lancet, we know that 5 billions of the worldwide population don't have access to surgery. So that is something, and we change totally. So that means when we discover that, we say we continue to work with the Ferrari, but we need to imagine something else, a low-cost approach for diagnosis and for treatment. So the challenge was very simple. We know that if we detect a tumor of less than 1 or 2 centimeters for the kidney, for the lung, for the liver, we don't need to operate the patient. We can do an ablation by radiofrequency or cryoablation. So what we did, first of all, it was the beginning of very low probe, ultrasonography probe, $500. But with artificial intelligence, with this probe, can be with a cable or Wi-Fi, we can have an automatic detection of little tumors of less than 2 centimeters. And that was done in 13 months due to artificial intelligence. Normally, a work like that will be more than 5 years. And after that, we said we need absolutely to transform this 2D image of the low-cost probe in a 3D image. That was done. And after that, we need also to think about a low-cost robot to do the radiofrequency or the cryoablation of the tumor. And that is a program we have done. So look, that is on the mannequin, but all the data are from human, the automatic detection of the mass. After that, we want to have a 3D image. So it's a really low-cost robot, but we need a robot because we need to have the same pressure. And you see, we have an acquisition of more than 150 images per second. And because we have this kind of possibility, immediately in real time, with a low-cost probe, we have the 3D image and the visualization of all the vessels. So it's so easy for a surgeon or with a support of a robot to do that. I just want to do some word about the training because it's time. We cannot imagine this kind of development of new technology without a training. And that is also one of the reasons has been created by really the push of President Paul Kagame IRCAD in Africa, in Kigali. That is my generation. I was trained like that in New York. You imagine that was more than 40 years ago when I was resident. And you see, impossible to learn something. Today, everything changed. We are connected every day, every morning with 3 auditoriums with the best operating room in the world. We want to teach how to operate a gastric cancer. The only possibility is not to be connected in the United States or in Europe. No, they have not enough case. We are connected with South Korea because each department has more than 1,500 cases per year. Today, if we want to teach how to operate cancer of the liver by minimal invasive surgery, we are connected with China because the anti-cancer of Shanghai, they have 4,000 cases per year of minimal invasive approach of cancer. After that, you see the training, they go up, like in IRCAD where you are, in IRCAD Africa, they go up in the lab because they need, it is a companionship surgery, the same for endoscopy course and for the robot. And today we start by 1 robot. We have 32 robots, intuitive surgical robots, but a lot also of Medtronic robot, Cambridge Medical robot with a lot of new platform. And for the surgeon, especially for oncologic surgery, we have developed, and that is free of charge, WebSearch, which is a virtual university on internet that is translated in 7 different languages. It is free of charge, and you see we have 500,000 of active members. So it's totally interactive. They can really learn a lot about especially the strategy, but also the technique. And I finish now by the globalization. Impossible to do research and training in only one center. And you see that today IRCAD is totally around the world, except today in Russia. But you see, we have one is going to be finished in United States, in Charlotte, in North Carolina, 2 in Brazil, Sao Paulo, Rio de Janeiro, 1 in Beirut in Lebanon, 1 in India, 1 in Taiwan, 1 in China. And you have seen 6 months ago the opening ceremony of IRCAD Africa, which is exactly the same standard than IRCAD France. So thank you very much for your attention. It was a pleasure to share that with you today.
Thank you very much, Prof. Jacques Maresco. That was wow, AI. But I really like the real life part of it, because that's where we have a gap, and that's why we're here today. So it's my privilege to welcome our next speaker, who is the keynote speaker, and this person happens to be my lecturer, so that's why I'm privileged to welcome him. Dr. Jerry Ndumbalu. He's a clinical and radiation oncologist from Tanzania, and he's also a founder and president of the Tanzania Oncology Society. Shikamo. Karibu sana.
So as introduced, I'm Dr. Jerry Ndumbalo. I'm a clinical and radiation oncologist. I'm also, as she introduced me, a senior lecturer at our Muhimbili University of Health and Allied Science in Tanzania, and also a founder and a first president of Tanzania Oncology Society. I have a very short presentation just to state or to see what are the gaps and where we should go. So as I said, we published this article in 2022-2023 with the Lancet, and it's basically, we involved the whole of Africa. And we had representatives also from here, Rwanda. We had a Fidel and Christian, Dr. Fidel and Christian as well from here. But it was represented from all over Africa to know exactly what is the situation currently in terms of the cancer care, especially after we have been crippled with the COVID era. So the estimation has already been given. Dr. Islam, and as well as they stated regarding the burden of cancer. It is very rapidly growing. The estimates showing that we are going to have almost 1 million patients in sub-Saharan Africa by 2030. And as I said, COVID burden made this situation worse. So we had to intervene to know exactly where we stand so that we can plan for our future. So this is very important that most of these plans, anything that you are doing, you have to have a political a political support. So what we did is to launch this report. We wanted the president of Tanzania, Honorable Samia Suluhu Hassan, to launch this report. And basically she agreed to launch this report. And just a day before the launching, she had another commitment, so she couldn't make it. But the whole delegates from the level of Prime Minister's office, a minister for health herself on yellow jacket, and also we had a minister from the Zanzibar Revolutionary Minister for Health on Zanzibar on the red tie. So all the delegates basically and all the leaders in health in Tanzania and East Africa, we had a representative also from from Rwanda, the ambassador from Rwanda, and all other African countries that were there. So this is very important that because most of these plans, they involve directly the government as well as the ministry, our Ministry of Health. So this was our very first target. We involved, we had a political will. So basically this report, as I already pointed it out, we had gaps that we saw in the whole Africa, and basically it was uniform. From all these regions, all these countries, we had almost same problems. So the very first one was registry. So most of our countries, we don't have cancer registry. You cannot plan if you don't have information. You cannot plan if you don't know the burden in the country. Most of these data that you are seeing, 19,000, whatever in sub-Saharan Africa, most of them, they are estimates. We don't have actual data from our setting. Most of these, you see GlobalCan, they are projecting them. So we don't have these actual from our country. So the very first thing was we don't have cancer registry. The other ones was cancer control plans. Most of the countries, there are several countries that they didn't have even a cancer control plan. You know, most of the countries, they were putting cancer in this NCD bucket. Everything is put there. We have a national NCD strategies and all that. But some countries, they didn't have specific strategies for cancer. And this is bad because when you have diabetes and you have hypertension in one basket, then definitely your cancer will be pushed aside. So we have to have the cancer. And also, we talked about universal health coverage, screening and detection, palliative care, oncology workforce, research, and also telemedicine, as I said, because of COVID era. So I put this statement here. This was stated by our Ministry for Health from President herself. She said, we are taking seriously the report recommendation, including updating the national control plans and investing in developing cancer as well as the cancer registry. So this was a statement from our minister, who was the guest of honor in this launch. So call for urgent actions. These were actions. We had 8 actions that we wanted each country, every part of Africa, to work on them. And also we gave timelines as well, if you are to reach a goal. So the first one was cancer control plan, as I said. We have to have cancer control plans. This will take us for 5 years, 10 years, even 25. Some of the countries, they even have a 25-year plan on the health as well as NCD and cancer inside it. So this will help in accelerating our control. And there was a group of African presidents, ladies. They have their group that they are promoting screening as well as cancer control. And this also helps us easily to navigate in most of these governments because they are there, hands-on. They know exactly what is going on in terms of cancer care and prevention. So we had a time frame of 5 years that every country, at least, they have to have a direction when it comes to cancer control. The second one was data, as I already pointed it out, that we don't have information, actual information. Most of the time, we just rely on data that are from outside our environment, and most of them, they are just projection. So we don't have actual cancer registry from our hospital, from a community-based registry, so that we can have exact data. So we have given 3 years, maximum, for most of our countries at least, to establish these registries if they are not there. And if they are there, at least to strengthen them, to have actual data. So we have people from the RBC here. We have to take this thing and put it into action here in Rwanda. In Tanzania, we have established, we have hospital-based cancer registries in most of the centers that are treating cancer. We have 5, now 6 centers that are treating cancer, national centers, that they have their own registry. And we have started a population-based cancer registries in some parts. So we have one in Dar es Salaam, one in Mwanza, one in Mbeya, and one in Kilimanjaro. So with these population-based, at the end we'll have a national, because of the funding and all the resources and all that, you cannot start it at once. So we started it in patches. So we are expecting it maybe in 3 years, 5 years time, we'll cover the whole country. So data is very, very, very important as action number 2 in order for us to fight this problem. So we have the systems. So most of countries that we researched, health financing is an issue. Cancer, especially cancer financing, is an issue. We had, when we were in medical, in oncology school, we had this 4th term that we call it financial toxicity. You can have toxicity from the drugs, but there is also another toxicity financially that most of these people are sometimes even selling their lands, selling their houses in order for them to finance or to fund their health. So it is proposed that we have to have a universal health coverage in terms of the insurance in our countries. Some countries like Rwanda, I think they've got a bit a step ahead, but there are some countries they don't even have health insurance for even quarter or 1/10 of their population. So this is also argued for our governments and for all the institutions that they have mandate in terms of health financing, find ways, including health insurance that is universal for our people, So also in terms of cure now and cancer care in general. Prof was talking here about AI, and we were even, doctor said, wow, because it's a thing that we are we're inspiring to do it probably in the next years. But I can give you a short history about oncology in Africa, especially in East Africa. The past 5 years, only 5 years, we were not able to do any radiotherapy to the breast, proper one, head and neck, any brain tumors, because we didn't have any sophisticated machine. We just had a plain cobalt machine. These are the ones that you are limited, that you cannot do any of those sites that I have mentioned. But as currently I'm speaking, in Tanzania we're almost going to have like 5 new linear accelerators. 2 that are newly installed, will be newly installed at Aga Khan. Temel is here, please stand, they'll see you.
So actually, as Dr. Jerry mentioned, we are now about to complete 2 linear accelerator installation at Aga Khan Hospital in Tanzania, which are the state-of-art technology, and it will be soon, just coming weeks, will be ready for the patient treatments. And it's also a part of PPP project in Tanzania. And we are very proud to bring this technology for the public services especially. Mm-hmm. And we are very much looking forward to extend the same proof of concept for the rest of the African countries. And thank you again, sir.
Yes, so PPP also works. So in Tanzania we had this PPP, we had a program that called Tanzania Comprehensive Cancer Project. that is partnering between private and public. All in all, is just to have these machines that we don't need to send anyone outside the country for a very simple treatment that doctors are here already to do that. You just need the machine to come here. So this was also action plan that our countries, they have to invest in these treatments and diagnosis of the cancers because the main thing here is mobilization of resources. And resources are there. It's just the priorities. Most of our countries, the resource, if you are looking for it, basically, it's there. Just a priority. So in terms of improving cancer treatment and care, we urge our government, we urge private parties, we urge everyone, especially in terms of PPP, to make these treatments available. So ARCAD and France as well, we are probably in some years, you can even open a center here with all those robotics, and people in this region can access. So we had in the same PPP, we are partnering with one organization in USA that are bringing proton therapy in Tanzania, which is not available in all this region, except maybe in South Africa. So those are the kind of PPP projects that they will help our patient at the end. So it's not only the government, but also private and every stakeholders, they have to play their role. That was number 4 in terms of treatment and cure. So most of our patients, as you know, they come at a very advanced stage. Most of them, they are stage 3 and 4s. So we have to also invest in palliation. So in this study, when we were doing a background check, there are some countries that don't even have a morphine. And their policy of getting morphine, it was very, very difficult in some of the countries, which is just a simple drug that you can administer to patients and palliate them, because majority, as I said, majority of our patients are coming at an advanced stages. So optimal palliation, optimal pain management was one of our action plan that most of our countries, they have to invest on. And this one is not expensive. So in a year or 2 or 3, at least we have to have a national plan in our countries for us to establish this palliative and support program, as well as a rehabilitation program for our patients. Number 6 was workforce. I was just talking to Daktari here that we have, he was stating that Tanzania, we went ahead in terms of this action plan in building the workforce. We have training programs in Tanzania for oncology, nursing oncology. Now we are almost going to start a medical physics program. We have radiotherapy programs. And the only few African countries had these programs. So what we are commending, or what we want, we are recommending that we have to have these programs in our countries, because it will be customized based on your patients, type of patient that you are seeing, and your environment. I can give you a history. We had one physicist who was trained in Italy, and he was trained with, as you can see, the robotics and all those IMRT techniques. And when he came back to Tanzania, it was difficult even to do the basic simple stuff. He knows a lot. So we have to have these trainings locally. Yes, we usually partner with the outside to get the advanced technology, to get an advanced knowledge and all that, but at least if the training will be here, You will customize it based on the local environment. So we said most of our countries, they have to build their own workforce inside their country to be easier. And if you cannot, then you do the regional collaboration with the nearby countries, like what we do with Tanzania and Rwanda, to have these oncology programs and trainings. The 7 was research. We pulled out all the African literatures and published research in this project. And we mapped them, where they're coming from. So you can see 80%, probably 70% was coming from South and North. If I can say South and North, you know. So it was South Africa and Egypt, Algeria, Morocco on the north. So here in sub-Saharan countries, it was almost like 30 of the publications that we pulled just writing from Africa. You understand? So we argue that we have to have the information about our own patients. Because even these drugs that we are using, all these medication that we are using, even its toxicity, side effects, we have different genetic profiles. So the toxicity that the Chinese can get with this drug will definitely be different from our setting. So we have to have studies, we have to have research collaborations within the countries. Yes, we need partner from outside, but at least if we can study our own population, coming up with our own answers so that we can at least improve our cancer care and service. The last one was telehealth. As I said, during the COVID era, and even this project, we did it in COVID era. Everyone on their home. We had a lot of Zooms and teleconferences, and within that, we managed to come up with all these reports. So it's possible to use telehealth to improve our care. So as what Professor was saying, he was in New York and he can do something in another countries. We can also impose or improve in telehealth. In Tanzania, we've started in pathology, and also we are going to radiology as well. Pathology meaning that the sample is in another region, they just take a biopsy or whatever, even if it's FNA, or that they stain it, they scan it, and the pathologist is on the zonal hospital, maybe 300 kilometers away. So they just scan the slide, they send it electronically, they read the report, and they send their email back. So because of this workforce that we are talking about, we also have to make sure that we invest a lot in telehealth. This one, as you can see, during COVID era, as I said, we couldn't even fly anyone out. So it helps us a lot during consultations with doctors from outside. We did a lot of tumor boards with the people from different countries and help us improving the care as well as our outpatients outcome. So those are the 8 action plans that I wanted to share with you. And please, everyone on their part, every stakeholders, I think you have 1 or 2 action plans, 1 or 2 things that you can do from these 8 action plans. And if everyone does their part, I think in 3, 4, 5 years we'll be at the next stage or phase in cancer care. Thank you.
It's a pleasure to be here, and I apologize I came late. So if I repeat some of the things that previous speakers have already said, you will bear with me, or you can stop me, we've heard it, and then I can sit back. Regarding the background of myself, I am a pediatrician and a global health professional. Most of my work has been on maternal and child health, guideline development, strategy development, planning, and policy development. Right now, I'm teaching at Emory University in Atlanta, Georgia. So most of my comments might be a global kind of perspective, but I've been practicing pediatrics for the last several years before I joined the global health arena, and I usually am affiliated with one of the schools in Ethiopia. That's where I am from, so I get to practice here and there. So the background of cancer, we know that the burden is swiftly escalating. We know that the burden of cancer is escalating everywhere. But there is an alarming increase when we talk about cancer in low and middle income countries, particularly the African situation. 19 of the 20 countries that have high incidence were in Africa when we compared the LMIC rates. And I'm sure you've gone through this. The projection is also painting a grim picture. So by 2040, we know that we will have more than 2 million cancer cases. Despite that 80% of cancer is in low and middle income countries, only 5% of resources are available for cancer control in the region. So again, that is also another important challenge that we are grappling with. So increasing life expectancy, urbanization, population growth, and lifestyle changes may have contributed to this effect. Not to forget also the relationship between alcohol and cancer. I'm sure you have gone through some of the presentation, I'm not sure, or it will be coming. Alcohol has been known as a carcinogenic, and in breast cancer and others, there are several studies that we can refer to. When we look at the scientific developments, there are so many developments in the last decades. Innovative technologies, which have enabled us to understand cancer more deeply, have been very instrumental in improving cancer care, cancer diagnosis, cancer prevention. We talked about AI, and I'm sure we've covered that. Wearable technologies, and also in-depth understanding of the biology of cancer itself in treating intractable conditions like glioblastoma and pancreatic cancer has also made the headway in the scientific developments. Another one is modulating the human microbiome, which is the next frontier in cancer. So there have been a lot of scientific progress that has been made over the last decade that is helping improve the quality of life and improve survival of patients with cancer. But these technologies or these benefits are mainly concentrated in areas where you have the infrastructure, the workforce development, where you have institutions, and where you have the supplies that are available to make sure that you can use these developments to advance cancer care in your locality, and that is usually in the high-income countries. So despite all these developments, we are not benefiting as much as the other countries which are having the resources to move forward with improving cancer care. I don't want to go into the limitations. In general, we have a weak health system. But on a positive note, there is a great progress in the African region, one of which is, in fact, in this country, the human papilloma vaccination is more than 80%. There are a number of initiatives in multiple countries that we heard from our previous speaker. There is a progress that is moving forward that gives us hope that we will have improved cancer care for our population. However, these efforts need to be amplified, and we have to recognize the urgency of action and also our advocacy for our patients, and on also improving, influencing policy, and not only having plans and policies in place, but making sure that they are implemented, documented, and we are really monitoring our progress becomes critical. I just want to share with you one story when I was practicing pediatrics back home in Ethiopia. I think we all agree that cancer has a profound emotional weight, not only on the patient itself, but the families. When you have cancer, you have to think about what will happen to, if you are an adult with children, you have to think about this terminal illness and what you need to do to care for your loved ones. When it is a child, it's more serious. I find it very emotional when we see cancer in children. I had a patient who was 5 years old with cancer, and we were treating him with whatever was available, and this is a long time ago, and I don't think there is much has happened in terms of improving cancer care for children in Ethiopia, and for that matter, in many African countries. The chemotherapy regimens, they were not complete. If the child requires 2 or 3, we have only 1. Radiotherapy was not available. Palliative care was not available. And this was one of the patients I was very much, I don't know, somehow attached to. This was a 5-year-old, a sweet kid who comes once in a while to get treatment, having repeated relapses. And this child died. And I find that emotionally very heavy on my side. And I felt in saving this child, just because he lives, or this family lives in a country where we cannot afford to have adequate regimen, cancer regimen, to benefit our patients. And I think the pediatrics part, or the childhood cancer part, is in fact the one which is left behind. I don't think it's any better in the adult, but if we compare it, I think the children are left behind as well. So when we think of improving cancer care, we have to remember that we need to ensure that childhood cancer is also taken into consideration. Maybe it's because I'm a pediatrician, I'm voicing the childhood cancer here, but I'm sure all of you agree with me the psychological toll it takes in our communities when a child has cancer. So what needs to be done is, as already mentioned, we need to act urgently. I think we've been slow for a long time. I think it's time to kind of pick up the pace. I did say that there are improvements, and which are encouraging, and there are positive practices that are encouraging. There are so many steps being taken, and Rwanda is showing, the way ahead as well. But I think we need to pick up the pace in terms of cancer care. First and foremost is the plan. Many countries may not have a plan, but those who have a plan, they have to make sure that it is interpreted, implemented accordingly, and it's followed, monitored, and also there is a continuous improvement in the cycle of planning. We have to attend to the comorbidities like HIV, malnutrition, as well as the palliative care component, which is really very much also lacking in terms of attention in the health care field. Successful models are already existing. The psychological therapy or the psychotherapy that is required for parents, for families of cancer patients, and the patients themselves is also critical. Leveraging technology is also another main area or important area. This kind of meeting brings the idea of coming together, sharing experiences, learning from each other, and then creating opportunities for collaboration a reality. And I think that is what we need to also kind of embark on, and also make use of these connections to boost our work in the research area, in the implementation area, and also in the data sharing and information that is relevant for improving policy or influencing policy, because we are interconnected from the region. And I am very hopeful that these 2 days will give us some way forward for us to kind of identify areas of collaboration that will be coordinated and also improve our partnership moving forward. In conclusion, the efforts to prevent and control cancer and bridging the gap in patient care, research, and education could be addressed. They are not insurmountable. We can do it, but we need to have collaborative effort and advocate for our patients. Thank you.
Cancer itself, it's a disease that weaken immunity of a patient who is suffering from that cancer. If one has the weakened immunity, it means he or she is prone to infection. A patient may die not because of cancer, but because of communicable diseases, which are preventable through improved WASH performance.
Dear participants, it's truly a honor to me to stand before you today representing WaterAid as one of the privileged sponsors to the first E3 International Cancer Conference here in Kigali. And indeed, it's really, I feel a privilege really to be able to sponsor this conference, and humbles myself to be able to contribute to this wonderful, great conference. Cancer stands as a challenging adversary that affects millions of lives globally. And according to the International Agency for Research on Cancer, there is a growing burden of cancer with a disproportionate impact on underserved populations. And therefore, we all feel an urgent need to address cancer inequalities worldwide. WaterAid's mission is to transform the lives of the people by improving access to safe water, sanitation, and hygiene, the components that are all fundamental to achieving good public health. For the case of cancer, we strongly believe that universal and permanent access to clean water, sanitation, and hygiene are all essential to prevent and manage diseases such as cancer, infection prevention and control, as well as other pandemics. I saw one of the objectives of this conference is to explore strategies for delivering cancer care in regions with limited resources, focusing on innovative and cost-effective approaches, which I believe speaks to the mission of WaterAid. It's clear that clean water and good hygiene practices can not only prevent infectious diseases, but also contribute to the reduction in the development of several types of cancer. The association between water hygiene and cancer should be emphasized in various cancer prevention programs. Let me talk a bit here about the quality of water we use. Some water contaminants, like arsenic, constitute serious risk to the cancer of the liver, lung, bladder, and even kidney. And in our area of work, if some people are willing to invest in clean water, it's very, very few people who are concerned with the water quality. One of the requirements for cancer patients is healthy eating, including adequate consumption of fluids. But this cannot happen without availability of clean water and proper hygiene. The same applies to other tips to keep healthy life, like skin and mouth care, bathing, and others. You will also agree with me that clean water in healthcare facilities is very key to infection prevention and control. According to recent data from World Health Organization and UNICEF, there is 700 million people in the world who don't have clean water close to their homes. There is also 1.5 billion people who don't have a decent toilet to use. And globally, 3 in 10 schools, for example, don't have access to basic water. These statistics have faces, and we should not ignore them, especially when we think about cancer patients who might be included in those numbers without access to these basic necessities. WaterAid has reached millions of people in some of most remote areas in the world, but we must work with greater urgency because our target is to reach everyone, everywhere with those services. We are in 22 countries globally, but here in Rwanda, where we are today, WaterAid has provided water to almost 1 million of people. And more than 245,000 got access to sanitation, while 2 million people were reached with hygiene behavior messages. We believe that access to water, sanitation, and hygiene for all can be achieved, but it will happen only if all stakeholders in development and public health become aware of the impact that WASH has on health and other development areas. At this conference, WaterAid will be an unusual participant. discussing only about water hygiene and sanitation. I need to close by calling global leaders and future leaders and current leaders here in the room and decision makers to emphasize more and more on investing in water and sanitation and hygiene, so that together we can create a world where everyone everywhere has a healthy and dignified life. Thank you so much for your kind attention, and I continue to wish you great, fruitful deliberations.
Once again, let's give a round of applause to WaterAid.
Good morning. It's just a little cold. I don't know whether we need someone to wake us up a little bit. I can imagine both hungry and cold at the same time, not a good combination. It's a privilege to come to this conversation. Among other reasons, I believe we have made a lot of progress, and because of that goodwill, I think there's a lot of interest to see how we can grow cancer care in the countries that we work in. And looking around the room, I see lots of people who are really great partners, I think, to push us forward. So it's a good day overall. And I think today, compared to 20 years ago, when you looked at cancer or you had something like cancer, it was almost a pronunciation of death. So in many ways, we have been speaking to death, and we've made a lot of progress. I think we should give ourselves a round of applause in contributing to that. So Partners in Health is an NGO. We are not a profit company, hence there's no advert or anything like that. Our job really is to invest in healthcare, to improve outcomes of people who are vulnerable. Our investment is primarily through government establishments. We do not run a private entity. We are not a for-profit company. Ours is try and strengthen the government healthcare system. So as an NGO, we are really in every country invited by government, and we work within government institutions. We believe it's the most sustainable way of strengthening the healthcare system, not just vertical programs like cancer, but the healthcare system overall. And I think as we grow in understanding the challenge of cancer, I think we all appreciate that you need a healthcare system more than you need vertical interventions. So in the last 20 years, we've worked in Rwanda, and specifically in the last 12 years, our focus in cancer has been focused mainly in one hospital in the country, in Butaro Hospital. Now it's a level 2 teaching hospital. Our heartbeat really was to try and demonstrate in principle that we can have a cancer center with integrity, with quality of care in a rural setting, closer to people who most need that service. And I think we have been able to demonstrate that in principle. The center is located about 2 hours drive from here. It's set up in a government hospital at the level of a district hospital, a bit now uplifted. And we worked primarily to establish, number one, diagnostic services, because without diagnosis, you have no entry to care. The first point of investment is actually a quality diagnostic service. So we run probably the biggest histopathology lab in the country that supports other care centers as well in the country. Our next investment really was in establishing the infrastructure, building a hospital that was really centered on cancer care. It still serves other non-cancer needs, but the bulk of the investment, the bulk of the HR, the bulk of the trainings has been really centered on having a cancer center so that we can demonstrate that rather than private clinics where someone goes to a private physician, we can actually have a systematized approach to cancer care. And you have protocols that can be scalable at country level. You have innovations that can be reproduced in other centers. So that's been sort of our approach. It's mainly been a health system strengthening approach rather than a vertical approach. So we primarily offer chemotherapy. That has been the heartbeat of our investment. And as you can imagine, there's so many cancers. Our first approach was to look at the most prevalent cancers. So we focused on the first prevalent cancers, and over the last 12 years, we've been increasing the range of cancers that we can treat. But one of the realities you hit with cancer is that every cancer is like a disease on its own, separate from the other cancer, in terms of the histopathology, in terms of its cure rate, in terms of the treatment modalities involved. So every time you add another extra cancer, you're almost managing a completely different disease. And so it's a bit of a complicated system. And that's a reality, I think, as we sit here, we need to have a conversation on. It's not like setting up, let's say, an MCH department that can handle 12 diseases in one center. Every cancer is different. And so the resources needed, the capacity needed, the systems that need to be there, the treatment modalities have to be almost centered around that particular cancer. So that's one complication. The second complication is that, especially when you look at chronic diseases as different from primary healthcare diseases, we need to find systems that are patient-centered. We are far from where the West is right now, but when you talk to a cancer patient, in as much as they have a disease, they have so many other complementary challenges that need to be addressed in order for them to actually get the cancer they need. So we've been working over the last 12 years to transform cancer from a health facility-based approach towards a patient-centered approach. And we can demonstrate that, I think, in the growth that we have made. And we've seen that, for example, investing in finding equitable structures like patient navigation. We assume that when you send a patient to a hospital, they will find their way, they will be equally received, they will be housed, they will be fed. But we all know that's not true. And it's not enough to give someone chemotherapy. They need to eat food, they need to be housed somewhere, they need to get the other complementary radiation they need. And so for many of us, I think we need to look at it more from that approach if we're going to have the impact that is needed for that patient. We also need to be aware that we're working in resource-limited settings. And apart from the systems being suboptimal, the patients themselves can hardly afford most of these medications or even the diagnostics. So if we don't think systematically and we don't think innovatively around the other complementary support they need, especially financing solutions, we'll be able to have a service, but no one will access it. And so we've not done anything. So apart from bringing in drugs, and we've been catalyzing bringing in chemotherapy into the country at a time when we didn't have any other center offering that, but that has improved, and a lot of shout out to the government for a lot of progress in that. But apart from bringing in chemotherapy, we've been also able to think through how to finance or to provide finances for patients who come. So because we're an equity-driven initiative, we believe that healthcare is a human right. No one should be denied care. It's a lofty ambition, I agree. But if you come to our facilities, you will get care one way or another, whether you can afford it or not. So the challenge then is who pays the bill, but that's a separate conversation from the patient who came into the door. They should be able to get the care, if the care is available in the hospital. We believe that where you're born or your circumstances should not determine whether you live or die. So we do our best to make sure that there's equitable care, it's quality care, and that just because you do have or don't have resources, you should not be treated any less than the other person. So among other things, we were able to think through pragmatically. If you introduce a cancer center in a rural area, you will not get an oncologist coming. You will not get an oncology nurse coming. You may not be able to get a radiation expert coming. So we were able to catalyze and demonstrate from the very beginning task-shifting initiatives that could get capacity to people who are not specialists, but without undermining the quality of care. So we've been thinking through different mentorship models that involves us to bring in senior oncology nurses from the US who are embedded into the program for years to be able to really provide quality experience and learnings, but with hands-on approach rather than educational programs. Not to mean that an education program is not effective, but for most of these complicated diseases, you almost need someone to handhold you and to pass on skills and competence and experiences. It's not as easy as most of the other, let's say, non-medical challenges that we have. So cancer care is a lot more complicated. It requires a lot more experience. It requires a lot of mentorship. It requires a lot of complicated protocols and a lot of mentorship around navigating those protocols. So our model has been really task-shifting, has been really supporting mainly pediatricians and some of our obstetricians to actually act like oncologists and have those competences. And we've been able to demonstrate that. The good place we are in now, we have better capacity to hire oncologists. That doesn't undermine the previous cadres. We actually are able to work even better with a combination of both. Because then again, you may never get all the oncologists you need in a center as you work. Even within the cities, you may not be able to get that. I think what has really helped over the years has been also the availability of radiation. We used to literally fly out patients to get radiation to Uganda and then to Kenya. But now with Rwanda Military Hospital at the Rwanda Cancer Center, we are able to have access to radiation, and that has really improved not just quality of care or the speed of care, but just the convenience of the patient and the ability to be treated in a setting that is socially agreeable to them, and they can be supported even as they get care. Before that, if you fly someone out of the country, we often think they went for care, but we don't understand that human beings are complex. You need a support structure around you even as you're getting care, and we've been able to do that. Now, we are now leveraging on 12 years of experience and really showcasing from implementation science some of the lessons we are learning, some of the research that has been published, to try and see how much of those learnings can be curated towards improving care and expanding it outside just our hospital. So working with RBC now, we are improving on diagnostics, because again, previously, every patient would come to the center to have a biopsy taken, to have a tissue processed, and that was not going to be very feasible long term as more and more patients come in. So we are working at 5 centers now to improve diagnostics, hoping that these centers, because they'll be closer to patients, there will be increase in access. We are also working at really, for patients who need chemotherapy, oral chemotherapy, who don't need to be hospitalized, there's no point driving to Butaro. So we are looking to capacitate, again, 5 hospitals across the country to be able to provide oral chemotherapy and be able to follow up patients closer to their homes. If we do not make care patient-centered, we are going to be asking too much from people who are sick, and many of them are debilitated. And I think a colleague talked about financial toxicity. It really is not helpful to treat someone for cancer and leave them financially disabled. You've dug one hole to fill another, and so we need to do better. So cancer care for me is a holistic approach. Apart from just the AI information we are getting and all the advances in science, we need to think about the human being and the toll that they go through when they're getting cancer and the entire network structure that is needed to protect them as they get cancer. So I'll probably mention two paths that we are looking at in terms of growth. One is most of the medications that we have been using are relatively outdated. Cancer care is rapidly evolving, and apart from cost implications, access challenges are also becoming a challenge. But we are really challenged now working with government to improve on providing newer molecules that are less toxic and more impactful. That's a challenge that we are handling right now. The next challenge for me really is looking at integrated pathways of care. We cannot manage every patient in one hospital, even in the most advanced hospital. So we need to leverage the existing competences and see how we can partner with other people to provide cost-effective interventions for the whole country. 3 is, even with all these investments, the majority of the patients are still coming in late in their course of disease. So figuring out public health interventions or access initiatives that can identify people early on in their cancer journey will allow us to be able to treat patients better, get better outcomes, probably less toxic outcomes, but also be able to provide care for cheaper. It's a bit sad when you have the medications, you have the diagnostics, but the patient comes in stage 3, in stage 4. I mean, it's sad that the medication exists, but now the patient is far advanced and they cannot respond to the treatment. So if we can try to identify patients early on in their journey, I think that would be a lot of progress. But to do that, we need services that are much more patient-friendly. We still have a system, a healthcare system, that is passive. If a patient is sick, that's when they will come to you. But by the time the patient comes to you, they are too late in their patient journey. We need to find approaches that find patients much earlier on in their cancer journey before they even realize they're sick, or early on, which means we need to walk out of facilities and find cases closer to their homes. Or we need to rethink the way we are actually screening patients. We now have a mammography machine in Butaro, and I've been making the case that maybe we need to have mammography machines in supermarkets. Because by the time you identify you have a swelling, by that time you have lymph nodes, you have extended disease, it doesn't really make a lot of sense. And people don't generally come to health facilities to see whether they are sick. They only come when they are sick. So we need to be able to either be more intentional and proactive in challenging people whom we think are at risk to actually get early screening. Most of us, for example, in this room, I would guess, have insurance. But when was the last time you actually went for screening for cervical cancer, breast cancer, or any other cancer? We don't. We only do that when we start feeling some kind of symptoms. So we need to find a way in which we can mandate that either as part of health weeks, promotion campaigns, or other initiatives that can push people towards accessing these services, even when they are not feeling illness. But to do that, you need to invest in awareness, you need to invest in healthy living, rather than just sickness-driven parameters. We need to also work with insurance companies to be able to extend these services as part of their responsibility, not as part of a business, to make sure that, for example, if I'm 50 and I'm going to check my eyes, I should be able to have also my prostate checked. If we can do that in a systematic way, I think we'll be able to capture people early on in their disease. Fourth is, I think, even as we sit here and see all these advances, if we are not able to have strong advocacy, number one, to increase access to these opportunities, but also for them to be affordable, we will not make a lot of progress. We had friends come and share some of their modern solutions, but even if they offered that solution at the price at which that solution is produced at their companies, largely none of us can afford it. So then the question becomes, how do we really build an advocacy platform to be able to have access to those services at a much more affordable cost? Who pays that cost? I do believe that somewhere down the line, if you'd all agree with me, healthcare, education, water, these should be human rights. And if they are human rights, there should be someone who is mandated to provide that human right. We can then have other innovative ways of how those rights can be paid for, but as human rights, they should be accessible to all people. So as we deliberate in this conference, in these meetings, I hope we can look at, outside just what happens in a health center, look at approaches that can increase access, affordability, and optimal outcomes for patients and for communities. And for those of you who are here, I will tell you that as you age, you're more likely going to be a client in this service, hopefully not soon, which means that we need to set up systems that will serve us in the next 10, 20 years. That's just a reality if you look at the epidemiology of cancer. So welcome to this journey of advocacy. Welcome to embracing equity as really an initiative that pushes our mandate, and welcome to improving healthcare systems so that we can fight against cancer. Thank you very much.
Distinguished attendees, ladies and gentlemen, thank you very much having us opportunity to be a part of the first E3 International Cancer Congress. We are very excited to attend this one, and also I would like to specifically thanks to Elekta distributor and a sponsor of this great organization, TTR. So Elekta is a Swedish radiation oncology technology manufacturer and since 1972. So we are providing and manufacturing the state-of-art radiotherapy solutions, and in this regard we offer wide range of technology. Of course, these technologies, in summary, these are linear accelerators, that we currently have in 2 systems in Rwanda Military Hospital as the first radiotherapy systems in country. And also another technology and approach is the brachytherapy, which is a golden standard treatment modality when it comes to gynecologic cases. And also it's very important in the sub-Saharan Africa due to high incidence of the gynecologic cancers. And other than that, we do provide gamma knife technology, which is not only for the malignancies intracranial located, but also functional disorders and the vascular disorders treatments can be easily done with this one without an invasive approach. And also the last but not the least is that the MR-Linac technology, which is a combination of 1.5 Tesla MRI and the linear accelerator that allows clinicians to see the tumors in a crystal clear so that they can increase the treatment dose and reduce the treatment sessions so we can treat more patients in a more effective way. So, and also the Elekta's main approach is that to lower the barriers to access the radiation therapy for everybody. And as you all know clearly, radiotherapy is a big need and the gap when it comes to Africa. And also this is our company vision and the mission to help in this regard for the entire sub-Saharan Africa. And what I will say as a last word for this part, thank you again. As Elekta, we are on your service and we are very proud to bring these solutions and also we would like to increase the collaboration and the partnership to providing the radiation therapy solutions to entire sub-Saharan Africa. Thank you.
Good morning, and thank you everyone for coming in today. I would like to express my gratitude for having us in the conference today, and I would like to thank our partner here in Rwanda, Transfer Technology, for giving us the opportunity to be present in Rwanda. We at Paxera, we are a US company, and what we're doing is we're offering radiology software solutions. And by offering radiology software solutions, what we do is we bring in the best practices that we have seen across all the countries we have worked in. Today, as we listen to different speakers, we have seen multiple points that we have already overcome in other countries. One of them was the one discussed by Partners in Health, where they were discussing that we do not want to help cancer patients. We want to prevent cancer happening. We want to reach out to patients. We want to help in early detection. One of the initiatives that was created in Africa was the Women Health Initiative, where portable mammographies went to women in district areas, in rural areas, to make sure that we help them in early detection. Allow me to give you a little bit of an idea about the radiology software solutions that we offer at Paxera and how those solutions align perfectly with the purpose of this conference today. At Paxera, we firmly believe in the power of AI. We believe that the potential of artificial intelligence, machine learning, and cloud computing is the way to revolutionize how cancer is diagnosed, is the way to help cancer being monitored and treated. We believe that the potential of AI in the field of oncology is through leveraging on different algorithms, machine learning techniques. What happens is a large set of data can be analyzed in minutes. Instead of taking months to create AI algorithms, it can be done in a couple of days, using the data sets for each country and for each genetic formulation of each population. What we do is we're committed to developing innovative AI-driven solutions that aims at empowering healthcare professionals and hopefully contributing to a world where cancer is not only treatable, but preventable. As we gather here today in the heart of Rwanda, we are reminded by the immense potential of growth and progress in the African continent. We're committed to being active participants in the advancement of healthcare in this region. With conclusion, I would like to extend my gratitude for the organizers, and hopefully we will have the chance to communicate further during the rest of the time in the conference. Thank you so much.